you, Sachin. And the last speaker is Dr. Vanashri, and I am sure she is going to.
Good morning, everyone. First of all, I'd like to thank Dr. Balla sir for including me in this session. I'll quickly go through this because of lack of time. So I'm talking about post-cataract surgery refractive surprise. Now, in today's world, the definition of a refractive surprise would be any deviation from the intended target that we have kept for the patient, so which can be highly unsatisfactory for both the patient and the surgeon. So there are a lot of factors like preoperative, intraoperative, and postoperative which can lead to a refractive surprise. I'll not go through the details because this has been covered by the previous speakers about doing a correct biometry to measure the correct effective lens position using of the appropriate IOL formula and then reaching the exact IOL power that we need for that patient. But there are certain conditions, as we know, that people like those having a high hypermetropia, high myopes, post-refractive surgery patients, dry eyes, post-keratoplasty patients, these are the ones where you'll have faulty biometry and we need to be extremely careful with the use of your formulas. So I'm not going into these details. Coming to directly, if now we have a situation where there is a refractive surprise, so what do we do? So we need to find out what was the exact cause, what has gone wrong, so that we can correct it. So do a subjective refraction at post-operative 1 month if it is your patient. Do a complete dilated examination. Recheck the patient history, surgical records, the IOL formula used, the choice of IOL that has been used. Repeat your biometry, keratometry. Do an OCT of the macula to see if there's any cystoid macular edema. And if none of these factors have gone wrong, then probably there was some error in the calculation of the effective lens position. So the first thing to do is medical management actually. You have to determine the patient's expectations. So we need to give an adequate chair time to discuss the situation, be honest with the patient that, okay, this has happened. Now this is your refractive error at present. So what is his expectation? If he's okay with a little bit of myopia of -1, you can say that, okay, you'll have a little bit of better reading. Or if the patient is totally unhappy, then we have to, go ahead and do something more and get the patient to probably emmetropia. So what are the options that we have? So first is your IOL exchange, or if it is a toric IOL, then it may be needed to be rotated. If the IOL has got fixed into the back, then it is piggyback IOL is the option. A very good option is cornea laser refractor based procedures, that is PRK or LASIK. And another recent advance has been the light adjusted IOLs, but we don't have it in our country as yet. So another thing to remember is you could have a capsular block distension syndrome. So there could be viscoelastic which could be stuck behind your IOL in an early case. So that can cause a distension and pushing of the IOL anteriorly, and that could be giving you a myopic surprise, myopic shift. So please do a careful slit lamp examination because here you don't need to exchange the IOL, but just do a capsulotomy to release the visco or the fluid. So if it is a monofocal IOL and the patient has come early on, with like 2 to 4 weeks after the surgery, so what are your options? So the first option here would be an IOL exchange because if it's a hydrophilic lens, then you can easily go and change the lens. Even in a hydrophobic lens, in early situations, you can easily go ahead with an IOL exchange. Second option would be a piggyback lens, and third would be PRK. But if the patient is coming late, say after 4 to 6 weeks, then adhesions would have formed and piggyback lens would be your first choice. And PRK and again LASIK, but you'll have to wait for 3 months if you want to plan LASIK. I'll just talk about the toric IOL surprise. Now, if you have a toric IOL surprise, then the tool to use is astigmatismfix.com. This will actually give you the idea whether the IOL that you have placed is it going to help only by rotating the IOL? Can you reach to a good refractive error at the end? So what you have to do over here is you have to feed in, if you can see the cursor, you have to feed in the cylinder power of the IOL that you have used, the axis at which it has been placed, and what is the current refraction of the patient. If you feed this data, then the software gives you an idea whether rotation of the lens will help or not. Now, if you see this example, here rotating the IOL will not fully correct the expected refraction. Hence, the way to go over here won't be a rotation, but you'll need to exchange the lens. Quickly talking about the piggyback IOLs. Basically in piggyback IOLs, you need the primary IOL to be intact in the capsular bag. You need a deep or a normal AC. There should not be glaucoma or pigment dispersion, and the endothelial count should be normal, and it is the choice of procedure for hyperopic errors. So these are the calculation formulas that you can use for the same. So this is the Sulcoflex lens that is one of the examples, a very good examples of piggyback IOLs which we can use. And I won't go into the details of the light adjustable lenses now. LASIK, we can plan, but that's a very good option for small errors, but we need to wait for 3 months after the cataract surgery. PRK can be done after the refraction has stabilized. The important things to remember is thin corneas, Fuchs dystrophy, basement membrane dystrophy, or severe dry eyes. These are contraindications, so we need to be careful here. A word of caution, any additional surgery will be carrying a risk of loss of best corrected visual acuity, infection, complication related to the anesthesia. Now these risks are always slightly greater than the initial cataract surgery. So we need to be careful, weigh the pros and cons and then go ahead with what we plan for the patient. Thank you.
Yeah. Thank you, Dr. Vanashri.